It is now my privilege to introduce our faculty. Kelsey Biswa, CRGS, General and CEUS Sonographer, Specialty Director at Sonography Canada, and Christine Merrill, BSc, CRGS, CRVS, RDMS, RVT, Sonographer, Department of Radiology, University of Calgary, Calgary, Canada. Christine.
Thank you for coming today for our webinar. We're going to talk a little bit about how do you get those images, so optimization for CEUS scanning, and we're going to include a little bit about liver masses. I'm Christine Merrill, and I have with me here Kelsey Brisbois, and we'll move to the next slide. First of all, we would like to thank everybody and say welcome from the co-presidents of ICUS, Dr. Steve Feinstein and Dr. Stephanie Wilson on their behalf. And we want to express our appreciation to our friends at Northwest Imaging Forums, the exclusive CME provider for ICUS, for their support of our educational programming. And we thank each of you for your interest in today's webinar and encourage you to register and join us for all ICUS live and recorded webinars available on our website and the mobile ICUS Connect. Next slide. So ICUS, a little bit about ICUS. It's a global professional society solely focused on contrast-enhanced ultrasound, and we have members from all over the world. Next. So ICUS is free to join. All our webinars are free. You can access it by the code on the front here. And we have a free website, mobile app, and we have, of course, CEUS News Monitor, which has the latest contrast-enhanced ultrasound news and members in about 60 countries. Next. So we have a commitment to contrast-enhanced ultrasound. It's a safe, portable, radiation-free, and it produces high-resolution, real-time images of the cardiovascular system, major blood vessels, and organ and tumor perfusion. And also we have, as brought to you by these webinars, a commitment to free CEUS education for all medical professionals around the world. Our 2024 calendar, our registration are now available on our website, and all our live webinars are recorded and available free of charge on the ICUS website and mobile app and ICUS Connect. Of course, ICUS also participates in social media. We have Instagram, we have a website, we're also part of X, and you can find all sorts of educational features on the Instagram app and the website, including cases of the day. And each case features dynamic images, quiz, and teaching points. And they involve both abdominal and echo cases. In our next slide. And of course, for all the sonographers out there, you can find our Sonographer Training Resource Hub, which has free CEUS training tools for sonography educators and students. It has a scalable plug-and-play curriculum, resource modules for sonography training, anything that you need to know, including injection, contrast agents, it's all on our website. And it's developed. And you can download the ICUS Connect app, which also has a link to the website. You can test yourself on cases of the days. Product labels and information are available. There's a sonographer training hub, and more. And it's available for both Android and Apple devices. Next. And then, of course, our CEUS News Monitor, which is emailed, and we get global trends and development, bubble news and trends. You can visit our virtual exhibit booths. There's just so much information that you can get from being part of the ICUS crew. Our next slide. So explore our website with our webinar calendar, registrations, how to set up a CEU lab, case of the day challenges, and next slide. And so we encourage all of you to join ICUS and become part of the global CEUS conversation. Okay. So with sincere appreciation to our sponsors, we'd like to just acknowledge them for their generous support of ICUS and their leadership in the ultrasound field. And this includes Bracco, Lantheus, GE Healthcare, Canon, Philips, Siemens Healthcare, and of course, Denton's, Fat Roman Studios, Northwest Imaging Forums, and Custom Media Labs, Live Media. Okay. Next. And today's agenda, we'll skip on to this slide. Okay. And so ICUS wants to say thank you. We appreciate your interest in today's webinar, and to learn more and to connect with the global CEUS community, join us on our website, which you see right here. You can download the ICUS Connect app, or you can follow us on Twitter. Next. Okay. And we'll just bring up the presentation and we'll get started. So Kelsey and I are going to talk a little bit about how do you get those images. We have find that we're getting growing interest in knowing what we're doing when we're out there. We're not going to focus on pathology or liver mass or liver resolution today, but we have a small focus on how to get images for liver masses and how to optimize those liver masses. But we'd also like to acknowledge Dr. Stephanie Wilson. She is always integral in the design and the input of these presentations, and we are both sonographers in her lab. Disclosures, Kelsey and I have nothing to disclose. So a little bit of background. So traditional ultrasound has intrinsically high contrast between blood and solid tissue, so we see it well. Large vessels are well visualized without a contrast agent, and Doppler is a powerful and effective tool that can quantify hemodynamic parameters, including flow direction and flow velocity. So microbubble contrast agents extend these capabilities into the microcirculation, and this is really important because what happens is this redefines the role of ultrasound in resolving vascular questions previously left to CT and MR scan. But it's really important to know how to obtain optimal images of diagnostic quality. So we're going to talk a little bit about that today. So optimization for CEUS imaging includes knowledge of three important factors: the bubble, how their unique properties impact patients; the patient, how to position your probe and coach your patient for a successful exam; and the machine, how to tailor your software and settings for great CEUS images. And of course, the most widely used application for contrast today is liver-specific imaging. So although we're not going to go into the algorithm, we're going to talk a little bit how to image for liver lesions and about contrast phases and image acquisition. And then at the end, we'll pull it all together. So let's start with a little bit about the bubble. We're going to look at microbubble properties, how this affects imaging, and how we've created a new software design based on these microbubble properties. So our bubble design. So our bubble consists of a gas-filled core. The most common gases that we use today in North America are perflutrin and sulfur hexafluoride, and these are stabilized in circulation by a lipid shell. We know that abdominal image acquisition with microbubble contrast agents is unique from grayscale imaging. So it becomes really important to have knowledge of the microbubble contrast agent properties in order to optimize your image. So we're going to have a little bit of a look at that. So our bubble design. So bubbles are easily introduced into the vascular system via intravenous injection. They have no nephrotoxicity. And what bubbles do is they modify one or more acoustic properties of tissue that can be detected by ultrasound imaging. So what makes contrast enhanced ultrasound possible? So a little bit of the physics behind it. So tissue is a linear reflector. And what does this mean? This means that the return frequency from tissue, from the insulating pulse at a low mechanical index, resembles the insulating ultrasound pulse. And bubbles have the capability to be a nonlinear reflector. And what does this mean? The return frequencies from bubbles does not resemble the insulating pulse. So we're going to have a look at a graphic about that. So tissue and blood reflect at the fundamental frequency, where microbubbles reflect at both the fundamental and harmonic frequencies. So microbubbles are injected into the bloodstream, and then those vibrating microbubbles produce a large oscillation or resonance from a small driving ultrasound force. So ultimately, a big signal is produced. So how does the machine tell the signals apart from the tissue and the bubble? Well, we're going to start by the insonating pulse. So two pulses are sent from the probe. We have a fundamental pulse, and then we have a second pulse sent from the probe, which is 180 degrees out of phase to the first pulse. This technique is called pulse inversion, and it's critical to contrast enhanced ultrasound. So let's demonstrate what happens to the returning echoes from bubbles and tissue when we use a pulse inversion technique. So this is an example of the returning echoes from tissue. So you can see echo 1 waveform, and you can see the echo 2 waveform, which is 180 degrees out of phase from echo 1. And when you sum these two, the summation of these two waves gives you a net zero signal. So when you subtract them, you get no signal. And this is really important, and we're going to look at this concept a bit. So how do microbubbles work? They oscillate when they're exposed to a low power field. And the returning echo from bubbles, so you get two waves here, you see echo 1 and echo 2. The two waves resemble each other. And when the summation of the phase from the summation of the bubble waves creates signal enhancement, and we call this, this is part of the nonlinear properties of bubbles. So our imaging impact, we have the ability to subtract linear echoes from tissue, creating a microbubble-only image, and then we get an enhanced signal return from the bubble. And this fundamental principle makes contrast imaging possible. So our software is uniquely designed to display these signals coming back from the bubble. So what do we have here? We have a grayscale image on the left. So this is a low MI grayscale image of the liver, and you can see a small lesion in the center here. And on the right-hand side, we have a micro bubble. On the left-hand side, sorry, we have a micro bubble only image. So you're seeing a subtracted grayscale image, and the only thing that you're seeing here is vascular or blood flow or signal from the bubbles. And what is the effect on imaging? Well, you have a grayscale image here, so you can see a liver, and you can see a large mass within the liver. And what happens with our pulse inversion technique is the echoes from tissue are subtracted. So you lose your grayscale image, and then once you inject your microbubbles, you get a blood vessel only map. And we have the ability to watch this blood flow change over time. So here you can see a liver, you can see the lesion full of blood, and you can see the lesion change over time when the lesion gets a little bit darker. So for the first time ever, this is really important, ultrasound becomes competitive with CT and MR. And as Dr. Wilson says, it makes ultrasound relevant. So it's also important to know that microbubbles are destroyed when exposed to a high power field. And we're going to have a little bit, we're going to have a look at the impact on imaging. So mechanical index is a measure of power, and it's indicated on the software platform, and it's an important concept that affects the image. So awareness of mechanical index and scanning duration are essential. So we're going to focus a little bit on the bubble properties and what happens when we destroy these micro bubbles. So mechanical index, as we mentioned before, is a measure of power. It's static on some machines, and it changes with probe and focus on other machines. So it's important to note before you do any kind of scanning, your mechanical level index prior to each injection, because if bubbles exposed to a high mechanical index are disrupted. So what do we have in our image here? We have a small picture. What we've put water, and then we've put bubbles in the cup, and then we put a probe in the cup. We've purposely on the left-hand side increased the mechanical index to 0.6. So this is probably double to triple what a normal mechanical index would be for bubble imaging. And you can see what happens. Those bubbles are destroyed, they're swirling around in the cup. Whereas on the right-hand side, we have a low mechanical index. So you can see the mechanical index is at 0.08, and you can see the bubbles are maintained in solution, and there's even bubble distribution from the near field to the far field. So this is critical in our contrast enhanced imaging. We're also going to look at a couple other imaging impacts and considerations of bubble destruction. So here we have an image of a liver with the low MI grayscale on the right, and then the contrast image on the left. And you'll notice, what do you notice about the contrast image on the left? Well, in the near field, or at the top of the liver here, it's black. So we have no bubbles in the near field. So this happened when we were scanning because our mechanical index was too high. It blew out the bubbles in the near field, and we are maintaining some bubbles in the far field. This can also happen with increased scan duration. So it's important to be aware of mechanical index and how its properties affect imaging. So the goal that we want to attain is even bubble distribution. This is from the near field to the far field. So again, we want low mechanical index and we want intermittent scanning. So on the right-hand side here, we have an image of a liver, and you can see from the near to the far field, we have even bubble distribution. We have a low MI, which allowed us to create this image. So more bubble properties. How big are they? So a red blood cell is about 5 to 8 micrometers, and an ultrasound contrast bubble is about 1.1 to 3.3 micrometers. So this is unique to ultrasound contrast agents. And microbubbles are a pure blood pool agent. They do not leak outside the vascular system. So unlike MRI or CT contrast agents, microbubbles are too big to pass through the vascular epithelium. So every single from a microbubble directly reflects blood flow. And because of the relatively large size of the bubbles, it's possible to resolve the presence of enhancement from even a single bubble. So what is the impact of this? So on the left-hand side, you can see we have our conventional color Doppler. Now, color Doppler is excellent. We see big blood vessels, and we detect fast-moving flow. On the right-hand side, we have our contrast image, and the grayscale has been subtracted of the same liver. So you have the same big blood vessels, but what's interesting here is you can detect blood flow at the capillary level. And so here you can see that as the contrast comes in, you can see the third to fourth order level of branching with contrast enhanced ultrasound. So we can see the perfusion of anything we look at, and it's a pure blood pool agent, so it does not leak outside of the vascular system. So we're just going to have another look at the imaging impact of a pure blood pool agent. So our first image is an MR image. So you can see there's a mass there, sort of a subtle sort of mass that looks brighter than the liver. On CT, you can see the exact same mass with a little more impact. It looks brighter on the liver than the liver behind it. And so the CT scan, this is a large solid mass. So what's interesting, on contrast enhanced ultrasound, we have the exact same mass, and we can see it in real time. And these microbubbles are a pure blood pool agent. So you can see that the fine strands of vessels within this mass. And when we show it live, you can actually see the blood flow pattern. So you can see that these vessels are coming from the inside to the out of the mass. So it has incredible resolution, and it can show a pattern and branching of perfusion in real time. Another property of microbubbles is they are sparse in circulation. So what does that mean? There's only 200 to 2,000 microbubbles per liter of blood. Too many microbubbles can have a detrimental big impact. So we call this sound absorption. A small amount of ultrasound contrast agent has a beneficial big impact. So bubble manufacturers advise dosing by weight. But we have to bring to your attention too that new advanced software improvements may require less dose due to increased sensitivity. So this is a tip of the trade. In pediatrics and smaller patients, don't overdo it. You want to adjust per weight dosing and know your machine manufacturer's recommendations. So let's have a look at how this affects imaging. And I can't tell you how many times we have seen this in our department. We know that you get big signal enhancement from a small amount of microbubbles, and we know that too much contrast causes absorption of the ultrasound signal. So what do we see here? So this is an image of a liver. On the right-hand side, we see our grayscale image, and on the left-hand side, we see the grayscale image is subtracted, and we have a microbubble only image. Remember that we want to try and get microbubble imaging from the near field to the far field. Well, you can see in the far field of the liver here, all we get is a dark or a black signal, and this is caused by absorption of the sound beam from too many bubbles. So this is a tip of the trade, and we've certainly done this here. New users may confuse this with a software limitation or an issue with penetration. It is not. Optimization of dose will correct the problem. And I can't tell you how many times we've seen this, or even scanning for a longer duration of time. Once these microbubbles are destroyed, you'll start to see the back of the liver. And we're going to look at the impact of this microbubble property on a kidney. So this is a kidney. On the top image, you can see the kidney, and then you can see the spleen. And you can notice what's happening to the upper pole of this kidney. So it's almost like there's no microbubbles in the top pole of the kidney. And on the bottom of the kidney, there's this striking transition where we see all these microbubbles. Well, what's happening here is the spleen is a very vascular organ. So ultrasound contrast agents in the spleen are causing sound absorption, and you're not actually seeing the microbubbles within the kidney. But on the bottom image, all we did was we repositioned the probe. And as we repositioned the probe, you can see there's beautiful perfusion throughout the entire kidney and the upper pole. And there's uniform absorption in the entire kidney. So, and here's our still images as well. You can see the spleen causing bubble absorption, the upper pole of the kidney, there is no bubbles. And then once we reposition, you can see beautiful perfusion of the blood vessels in that kidney. Another property of microbubbles, they do not last long in circulation, although there are some contrast agents out there that do last long in circulations. The one we are commonly using do not. Microbubbles are exhaled through the lungs, and the lipid shell is metabolized by the liver. The most popular and utilized contrast today lasts for an average of 10 minutes in circulation until they are expelled. So what does this mean? Optimal visualization of contrast features requires the imaging of bubbles within a 0 to 6 minute time frame. Tip of the trade, you generally have 5 minutes to obtain your best images on whatever you're looking at, or you have 5 minutes to see the peak enhancement. So we're going to have a little, before Kelsey starts here, we thought it prudent to talk about the contrast software requirements, because these are important in the rest of the presentation. So we have a dual screen display. As we mentioned earlier, on the right-hand side, we have a grayscale image, and on the left-hand side, the grayscale image is subtracted, and we have a micro bubble only image. So you can see the lesion here on both sides of the screen. Calipers. We have a dual caliper on our software, and this is really important. So it will precisely correlate with the lesion on the other side. So if we put our caliper on the grayscale side of the screen, it precisely correlates to the microbubble side of the screen. It's very, very important. So you can see here, once we move the caliper around, it has the exact same action on the other side of the screen. And so we can put the caliper on the contrast side and it'll correlate with the grayscale, but usually what we're doing is we're putting the caliper on the grayscale side so we can see exactly what's happening in the blood flow pattern within the width of the calipers on the left-hand side, or the contrast only image. We have a timer, and the timer is really important because it gives us a continuous record of the time of injection. So we have the time of freeze of the cine clip, and then we have the actual timer as it's going. And we need to see both clearly visible with large font. So after our bubble properties, I'm going to hand this over to the fabulous Kelsey Brisbois, and she's going to talk to you a little bit about the patient.
Thank you, Christine. So now that we sort of understand the properties of our bubble, we'll look at what we need to do with our patient in order to get a good CEUS exam. So we're going to talk about body position. We're going to talk about selecting a window, orienting your probe, the patient's respiration, and we'll talk about scanning pressure and how all of these things affect the images that you can acquire. So When we start with body position, the patient can be positioned in supine, decubitus, or somewhere in between for a CEUS exam. But it's important to note that your patient should be able to hold still in that position for approximately 5 minutes, because that's the amount of time that you have to acquire your best images, as we just said. So when you position your patient, you want to pay attention that the area of interest or the target that you're looking at is as close to the transducer as possible. So now we're going to select a window. So our goal here is that we must essentially compare the characteristics of any mass lesion with the surrounding liver tissue. And so on the right-hand side here, you can see that we have 2 echogenic masses in this liver, and we're able to clearly separate them from the liver parenchyma. And so before we even start our CEUS, we're going to choose a grayscale window that shows both the lesion of interest and the adjacent tissue. And so what does that look like on contrast? Well, here you can see that we've added our bubbles in, and this becomes important because we're able to see how bright those masses are in relation to the liver. And you can see even throughout this single cine clip, we started off with masses that were brighter than the liver, and as we go on through time, they decline in brightness while the liver maintains the contrast. And so this is very helpful for us to be able to make a diagnosis about what kind of lesion we think these things might be. And that's a topic for another day, but those characteristics are incredibly important to note. When we select our window, we also want to consider whether a subcostal approach or an intercostal approach is going to serve us the best. So here we have 2 grayscale images of the same lesion. So on the left-hand side, we've used a subcostal approach, and on the right-hand side, we are looking at the intercostal. And I think most of us, when we look at these pictures, would prefer the image on the left. We've got a very starkly delineated lesion. We're able to see its position in the liver very well. We're able to show its echogenicity and its borders quite nicely. Whereas on the right-hand side, our intercostal approach is a little bit tougher. We've got some interference from the lung coming in on the left-hand side of the image. You can see that it's quite high up in the liver. And so based on the grayscale, many of us, I think, would default to this subcostal approach. But let's add bubbles and see what happens. So here we go. We've added our bubbles, and you can see them coming in here. Again, on the left, we have our subcostal, and on the right, we have our intercostal. And you can just take a moment and look at these clips and see the difference between them. So I'll let them run through one more time, and then we'll look at a still image of each peak enhancement and see how it makes a big difference. Okay. So here we go. So on the left-hand side in the contrast image with the white arrow, you can see that the lesion in the subcostal view is not looking very different from the liver parenchyma. It's quite deep in the liver, and it's a little bit more of a difficult delineation. Whereas on the right side, from the intercostal approach, you can see that that liver is easily visible, and that lesion is starkly different from the liver. So not just a change in position, but you can see how it changes our comparison between the liver and the lesion. And although we can revisit our grayscale and remember that we thought that the subcostal approach was better, for our purpose in contrast, this intercostal window happened to be better. So all this is to say that the optimal grayscale window you suggest may not always be your optimal CEUS window. So once you've found a window that you like, you want to orient your probe correctly. And something that we find a lot is that we rotate away from a traditional sagittal or transverse plane if required. So on the left-hand side here, you can see we've selected an intercostal window, and we've got a big rib shadow right through the center of it. But on the right-hand side, you can actually watch as this clip runs through. You can see that this technologist is actually turning the probe so that we are in plane with the angle of the ribs, so that we're able to move that lung shadow and that rib shadow out, and we're able to get a nice, clean, direct comparison between our lesion and our liver. Now, our big goal in obtaining images, which we'll talk about a sample protocol later, but one of the things we need to be able to see is a cine clip of the bubbles as they come in, which can happen up to about 50 seconds. And although we tend to use a big breath in or suspending respiration to get great images on grayscale, most of our patients are not on pearl diving teams and won't be able to hold their breath quite that long. And so oftentimes we'll use quiet respiration where the patients take small breaths in and out nice and evenly in order to try and keep things in the frame. However, we have to be careful about our probe alignment in situations like this. You can see in this video on the right-hand side, our probe is actually aligned either perpendicular or oblique to the plane of the patient's respiratory motion. So this lesion is only intermittently visible as it moves back and forth across the plane. Now, ultrasound is less affected by motion than other imaging modalities like CT or MRI, and we still have a very good resolution, and this is still a very diagnostic image. However, I think we can do better. So once we make a small adjustment, here we have moved our probe so that it's aligned parallel with the plane of the patient's respiratory motion. And you can see that the lesion is visible throughout the entire cycle of the patient's breath. And so a sagittal plane is often going to be in better alignment with that plane than a transverse. So we suggest that you maybe start there or consider it at least. Finally, we're going to look at scanning pressure. So this is an interesting one. In our top image, you can watch these bubbles come in, and they're coming in nice and slowly here. But what you'll notice is that we're actually getting bubble filling in the far field, but not so much in the near field. And this is kind of a funny thing because we only just introduced the bubbles to the patient. So we haven't had enough time for bubble destruction to occur. We never saw the bubbles hit that area, so how could they have disappeared? So this is actually caused by excess probe pressure. And so what we're going to do is if we decrease our probe pressure, we can look at the lower image here. You can see that same lesion filling up again, but you notice that we're able to prove that there is in fact normal perfusion on both sides of this lesion. So we're able to not only confirm that the liver doesn't have a perfusion defect, but we can also make a better comparison between that lesion and its adjacent liver parenchyma. All right, so we've talked about sort of patient factors and how we can manipulate those. So now we're going to make a final check on our machine before we start to perform our liver CEUS. So we'll talk about all the nitty gritty of the settings. So depth, gain and TGC, focus, and mechanical index. So in an ideal world, we're going to want to set our depth to something that's less than 10 centimeters. And hopefully we've used our tricks with windowing and with patient positioning in order to obtain a window where this is possible. Beyond a 10 centimeter depth, the contrast is greatly affected. So you can see on the left-hand image there, the little white star along the margin just shows where that 10 centimeter mark is. And you can see that that lesion is deeper than the 10 centimeter mark and how difficult that comparison is between the lesion and the liver because we're really not getting even bubble distribution from the near field to the far field. So on the right-hand side, we've made some adjustments and you can see how well we're able to say that that lesion and the liver parenchyma are different because we have pulled out a few tricks to get a little bit more bubbles in the far field. Now, you may not be able to move all of your lesions into that 10 centimeter frame. And if you're not able to do that, we just suggest that you select the best probe for the depth that you are working with. So it's worth a note that grayscale gain and contrast gain are adjusted independently. So when we start our CEUS, you want to set your grayscale gain to a conventionally appropriate level, I would say. So on our right-hand side, we just have kind of a schematic here. You have your low MI grayscale image, and you can turn your gain up, and then you can turn your gain back down. And basically, you just want to be able to identify your lesion very well so that you can put those dual calipers on and show the corresponding spot on the contrast. At the very start of your CEUS, the left side of your screen, so the CEUS part, should have a full tissue suppression. So you shouldn't, because you're subtracting the tissue, you shouldn't have any echoes. But the unfortunate thing about CEUS is that you don't know that your gain setting is appropriate until you put the bubbles in. So how do we solve this problem? So in order to know that our gain isn't too high, you can use a trick that is conventionally taught for color Doppler, where you turn the gain up until you get some speckle, and then you turn it back down until that noise disappears. So you know that it's close. And so that way you know that your gain isn't set too low, and you know that by eliminating the speckle, your gain isn't set too high. Your TGCs also should be aligned straight at the start of your CEUS. So your focus should be placed at or below the structure of interest, and focus set at the incorrect depth creates really profound differences in penetration and the bubble uniformity between the near field and the far field. So you can see in this video here that although we generally don't move the focus once we've started our CEUS exam, we created this clip to show the impact of changing focus in real time. And you can see how you almost get bands of brightness that move through the image, and how much we lose the far field when we have that focus placed too high. And so in order for that good comparison to occur, we need to keep it at a relatively steady state, but we also need to make sure that it's at or below the structure of interest. It is worth a note that new equipment has moved away sometimes from having a single focal zone and is focused across the entire image for grayscale ultrasound. In general, what we've noticed is that the contrast settings still do have a focus that you can set independently. So we suggest that you just double check your equipment before you start your exam. And finally, we've got this here, the mechanical index. So on some machines, or most machines, it is manually adjustable, and it typically ranges from about 0.07 to 0.10. The important thing is that it should be visible on screen during your scanning. So here we've got an example where it's located kind of at the top of the image, but you may see it along the right-hand side where they lay out your color Doppler parameters, where you maybe have your scale. So just make sure you know where that is going to be on your picture before you start your CEUS so that you can monitor it. And it is also worth noting that if you are using a probe with a higher frequency, such as, a high frequency curvilinear or a linear or an endovaginal probe, you will require likely an MI that exists at a higher end of this range rather than the lower. All right, so we've checked up on our liver, on our patient, and on our machine, and I think we're ready to start some liver-specific imaging. So I'll hand it back to Christine.
Thanks, Kelsey. That was wonderful. So now that we know a little bit about bubble properties, the machine, and the patient, we're going to talk about how to apply these image optimization techniques to liver-specific imaging. Liver is by far the biggest utilization for contrast ultrasound to date, so we felt that it was important to talk a little bit about them. And we're going to talk about contrast phases, and we're going to talk about image acquisition. Although we know that liver imaging has a algorithmic approach to diagnosis, we're not going to get deeply into that today, as it's not the focus of this presentation. So we're going to look a little bit about the circulation of microbubbles. So they're injected into the bloodstream, and what happens once they're injected into the bloodstream. So remember that they are a pure blood pool agent. So you can follow your bubble here. It moves into the arterial circulation. It goes into the capillary bed. Then it goes into the venous circulation. And then it's expelled by the lungs, as we said earlier, and then the lipid shell is excreted by the liver. Now we have an interesting image on the right-hand side of the screen here that shows how the bubbles traverse live through the vascular system. So this image is a microbubble-only image. It's just the grayscale is subtracted, and it's a picture of a transverse thyroid. So what can you see here? So this is the carotid artery, the jugular vein, and the thyroid. I'm going to restart this again. So as the bubbles come into circulation, you'll notice that they come into the arterial system first. The thyroid tissue is infused, and then they go through the capillary bed, and then they move into the jugular vein. So let's have one more look at that. So they come into the arterial system like our bubble. They go into the capillary bed within the tissue, and then they come down through the venous system through the jugular vein. So you can see it sort of slowly rolling around in there through the jugular vein. And this was an excellent video to show the start of what the phases are and how they happen within the body. But in the liver, we have a very unique blood supply. So we also have a portal blood supply. So it's really important to talk about this. And in the arterial phase in the liver, the contrast enters the hepatic artery and the small branches. And the hepatic artery and the branches are fully enhanced. The background liver and the portal veins are not yet enhanced, and this happens about 10 to 20 seconds after the flush starts. So here you can see our dual display, our low MI grayscale image, and in the arterial phase, you can see the hepatic artery coming into the liver. But you cannot, in the subtracted image, see any blood flow within the liver at this point in time. Something different happens in the portal venous phase, which is what we are looking at here. So when the contrast enters the portal veins, so you can see the portal vein here, filling is seen with the portal veins, and then the liver parenchyma becomes fully enhanced. So we know too that the dynamics of liver imaging, the liver gets 80% of its blood supply from the portal vein. So when I tell girls, once you see the liver parenchyma fill, you're starting to move into the portal venous phase. And ultrasound does a really great job of seeing this live. So let's look at a real-time dynamic display. So we know that CT and MR are a fixed single acquisition, but it's important to know what happens to the liver pattern of enhancement, because lesion enhancement patterns are always compared to the background liver tissue. So you can see here, we'll restart our clip. So you can see here the hepatic artery coming in. Then you can see the bubble enhancement throughout the portal vein. And then as the portal vein fills, you can see the entire liver parenchyma filling, because remember, the liver gets 80% of its blood supply from the portal vein. So although we see this really well live, we can see the bubbles coming in live, we do have specific timings for the arterial phase, the portal venous phase, and the late phase. So the arterial phase happens at about 10 to 20 seconds, and it ends at about 30 to 45 seconds. The portal venous phase happens about 30 to 45 seconds, and it ends at 120 seconds. And the late phase happens greater than 120 seconds, or 300 to 360 seconds. So it's important to know this timing, because when we do liver imaging, we need to accurately document what is happening in all phases for the best liver lesion interpretation. So liver lesion interpretation, there's two important steps to documentation. We want to watch that wash in the arterial phase. We want the comparison, as we talked earlier, between the liver lesion and the background liver tissue. And then we want to do intermittent imaging until the late phase. So remember, the reason to do intermittent imaging is because we will get inadvertent bubble destruction if we're continuously scanning. So remember that CEUS is real time, and your eye will not always perceive everything that happens. So that's why we like to make a movie clip in the arterial phase. But it's also important to make an assessment in all phases, including the arterial phase, the portal venous phase, and the late phase. So how do we do this? So here we have a picture of a liver lesion. So we start the timer at the end of injection or the saline flush. And then we obtain a continuous movie clip from the first bubble arrival to peak enhancement. And then we take a still image at peak enhancement. So here is our contrast specific software. Okay, you can see our dual screen display. On the right-hand side, we have our liver, and on the left-hand side, we have our bubble only picture. So all we're seeing here is enhancement from the vascular system. On the top You always want to note your mechanical index, which is 0.08. Sometimes adjusting the focus alone on these machines can affect the mechanical index. So before you even hit flush start, you want to look at your mechanical index, which is appropriate here in this case. And then also we have a timer, which you can see on the bottom. You want to hit the timer at the moment you say flush start, and you create the wash in clip from 0 to 30 seconds. And as Kelsey mentioned, you want to include your liver tissue and your lesion tissue. And then we take an image at peak enhancement. So in the portal venous in the late phase, we want to do intermittent imaging. We've talked about this before. Do not scan continuously. I've had problems with this in the past where people called and they didn't understand why they couldn't see anything at 3 to 4 minutes. It's because they kept continually scanning. And you want portal venous documentation of timing at 1 minute, 2 minutes, 3 minutes, and 4 minutes. So we're going to have a look at that. This is the same liver lesion that you saw in the arterial phase, and you can see at 1 minute, 2 minute. You can see the lesion starting to change. 3 minutes, the lesion changing in comparison to the background liver tissue. 4 minutes, the lesion is definitely darker than the background liver tissue. And if you can get it up to 5 minutes, the lesion is definitely darker than the background liver tissue. And we're going to talk about this in a second. This is where your dual caliper becomes important, because on the contrast, you don't know where the liver lesion is, so you need your grayscale to help you find it. But as it goes through 5 minutes, you can see what happens to the liver, and you can see this lesion really well. So this provides a very diagnostic picture of what's happening to this liver lesion in the arterial phase, the portal venous phase, and the late phase. And so in the late phase, the very late phase, ideal at 3 minutes, we sweep the liver and we look for washout. And we look for if there's bubbles. If there's bubble stability at 4 minutes, of course you can sweep the liver at 4 minutes, but this may be affected by a lot of things, including patient size, physiologic factors. But we'll have a look at the ideal imaging for liver lesions. So here on the top of the screen, we have the arterial phase. And you'll notice that we're taking a continuous movie clip from 0 to 40 seconds. And then what we've done here is we've created still images at 50 seconds, 2 minutes, 3 minutes, and 4 minutes. And you can see what happens to this liver lesion. It's starting to get quite dark at 4 minutes. This is important in our algorithmic diagnosis, which we won't get into today. But you've got beautiful comparison between the background liver and the lesion. So you can see exactly what's happening to this lesion over time. So we're going to put this all together. And we're going to talk a little bit about the bubble, the patient, the machine, and liver-specific imaging. So everything that we've just talked about to date. So when you start your contrast, this is a 61-year-old male. We know that he has Hep B cirrhosis. So this was our patient pre-scan. So we went in, we did our regular grayscale ultrasound, we sat down, and then we noticed on color Doppler imaging above that there's no color Doppler in the portal vein. This was important. So now we're going to add contrast to this image, but before we add the contrast, we have to think about our patient pre-scan and including our patient factors and our machine factors and equipment. So the patient pre-scan, so we're going to look at the body positioning. This is an intercostal scan. We have liver tissue for comparison. We're going to inject the contrast to see what happens to the portal vein. And then we can tell our color Doppler shows no flow. So we sit down and get the ideal position, and then we add our contrast. So we're going to talk a little bit about the bubble. So here's our dual display. We're using pulse inversion imaging. So on the right-hand side, we have our grayscale image, and on the left-hand side, we have our subtracted grayscale image, and you can see tissue perfusion. But what you're noticing here right away, so you can see the liver in the near field, is that when the portal vein comes in our bubble qualities, you can see we're starting to lose our image behind it. And as we keep scanning and we destroy the bubbles, then we start to see the image, we start to see the back of the liver. So what this is this is bubble absorption from the portal vein, but there's also something else interesting happening at the portal vein, which we'll talk about in a second. So we've already talked about our patient is supine, windrow selection, and of note here, Kelsey talked about respiration. You can see that the patient is quietly breathing and that the area of interest, which is the portal vein in this case, stays within the scan planes. And then our probe orientation, we've optimized this using an intracostal window, bringing it closer to the near field. And then we've opened up the rib spaces to see this. So, and then the machine, of course, we have our focus. We don't have it on the side here, but we've showed you, we've set it towards the back. Our gain and TGC are optimized not only for the contrast side, but for the grayscale side. It's a low MI. And then our mechanical index, we make sure that that's not too high, 0.06. But liver-specific imaging, so what do you notice about this? We talked about the phases, about the arterial phase, the portal venous phase, and then the late phase. Watch what happens when this movie replays as it comes in. And have a look at the bubble screen and watch what happens when the bubble comes in. What comes in first? Well, we talked about the arterial phase. The arterial phase should come in first, but it's not on this image. What's coming in first is the portal vein. So that means that we have an arterialized portal vein. And this is significant, although we're not going into great detail about this. This means that this is most likely a malignant portal vein thrombus, because it's not aligning with our specific phases. We should have the arterial phase first, the portal vein come in, and then parenchymal perfusion. But we have the portal vein first. We don't really see the arterial phase, and then we have parenchymal perfusion. So over time, with our liver-specific imaging, we actually did intermittent scanning. So at 30 seconds, you can see that the portal vein is fully enhanced. We should see arterial enhancement. At 1 minute, the portal vein is still enhanced. And at 4 minutes, you can see that the portal vein has gone darker. So this is caused by classic hepatocellular carcinoma, and this is malignant transformation of the portal vein or malignant thrombus. So this becomes a very important diagnosis that is easily made with contrast enhanced ultrasound. So Kelsey's going to take you through one more case.
All right, so we have one more example to show you about how we can optimize our images. So this is another case of a 31-year-old male who had a routine ultrasound for iron deficiency anemia that found an incidental lesion in the liver, and we were asked to further characterize this. So you can see on our grayscale image, we've showed it with the arrows. It's quite a subtle mass, so we can see it reasonably well on the grayscale ultrasound once we prepare our patient. So we had positioned this patient in supine. This is a subcostal window with a breath in. And so we're using that liver tissue for comparison. So because we're in a subcostal plane, we don't really have to worry too much about dodging between ribs. We've got a nice window to work with. So now let's add our bubbles. So when we start at the very beginning of this clip, and particularly in the near field, you can see how black it is in the background. And that's because we've achieved really good tissue suppression. So we've got our dual screen display, and that tissue suppression on the contrast side is what's allowing us to see that contrast with incredible resolution. And so if you watch this clip through, what you can notice is when those bubbles come in, we're holding that breath nice and still. And so we're only seeing the bubbles move, and they're moving sort of from the inside of the mass to the outside of the mass in a centrifugal pattern. So that will be important later. We've already talked about how we optimize for our patient. So the nice thing about using a big breath in for this particular mass is that because the patient has suspended the respiration and is holding still, only the bubbles are moving. So when only one of your patient or the bubble are moving, it's much easier to see these patterns. And so finally, we can do a checklist on what our machine settings look like. So we've got a good depth. We are able to say that our gain is appropriate because we're getting good fill and good reflectors in both the lesion and in the background liver. Our focus is again set to the back, and our mechanical index in the lower right-hand corner, you can see is 0.08, which is in that good range. So let's watch what happens to this lesion. knowing that we've looked at the arterial phase now, this clip is that arterial phase wash-in, and now we're going to look at our intermittent scanning. So over time, we've got in the upper left 1 minute, and then 2 minute, and then 3 minute images. And this really shows how important that dual caliper is, because we can see this image, this lesion, very well on the contrast image. But you see that as time goes on, this lesion is actually quite subtle. So we're able to look either at the contrast or at the grayscale image and place our calipers so that we can see the direct comparison on either side. And what we notice about this during our intermittent scanning as we move each minute is that while the lesion started brighter than the liver, it has faded a little bit, but not until there's less bubbles in it than the surrounding tissue. So it remains iso-enhanced to the liver all throughout that portal venous and late phase. So combined with our arterial pattern, we're able to say with confidence that this is a classic focal nodular hyperplasia and that this patient's incidental mass isn't something that we need to be concerned about. So in conclusion, we've looked at the 3 big factors that you need to optimize in order for you to get an optimal CEUS exam. So knowing about our bubble properties and how they impact your imaging will help you choose the correct dose for your patient, will help you troubleshoot when you notice that your images are doing things that you may not have understood. And now when you optimize for your patient, you can position them and your probe to coach them to get the most successful exam that you can. And when you look at your machine factors, you know how to use that software to your greatest advantage. And the understanding all 3 of these will help elevate your liver CEUS scanning. And our final thoughts is that throughout this presentation, we have showed an awful lot of videos about what not to do. And so that has all been things that come out of our lab and our experience. So experience is simply the name that we give our mistakes. Thank you, Oscar Wilde, for that gem, because it's certainly true around here. We thank you very much for joining us, and I'm hoping to open the floor so that we can have some questions.
So please utilize the Q&A button at your screen's lower menu bar to ask questions of our faculty here.
Okay. So the first question that we've got, and we'll answer this live, is will this slide deck be available after training? Absolutely. So ICUS also puts on its website, all its post websites. So you can go onto the ICUS website, you can actually find the link, and this slide deck will be available. And thank you, Anders, for your comment. And thank you, Brittany, from Orlando, Florida. So as we were talking through this, Kelsey and I have both I've been doing contrast for about 12 years, exclusively on abdominal imaging, and we're happy to share with you some of our experiences. And so there's a question from an anonymous attendee. Do you ever use these techniques for obstetrical placental issues? Yeah, that's a very good question. It has come up in our lab within the past and within the recent future. Although we're not using it for placental issues of interest, we are starting to use it because we know that this is a different presentation, that it's known that microbubbles do not cross the placental barrier. So we're starting to use it in patients like cancer patients or questions that can't be answered when pregnant patients can't go for CT or MRI. Okay, and a question, I hope that answered your question. So we do have some interesting pregnancy papers coming out. Do the patients have side effects after injecting the bubbles? So this is a really quite safe procedure. I can tell you that after doing tens of thousands of contrasts in our lab here with Dr. Wilson, we've really never had a serious adverse events. But yes, we've had mild reactions. Sometimes the patients with certain contrast agents can get back pain. We have had a few reactions with hives, but it's very, very rare. Overall, has quite a good safety profile.
And I think maybe something to note, Christine, as well about the contrast agent itself is, yes, it has a very, very low rate of reaction, but it's also, because it's not nephrotoxic, we find that it's used very much for patients who are in kidney failure or something else like that. It's a very safe way for them to get a contrast imaging modality without having to have something that will affect their kidney function.
Okay, so this is a really good question from an anonymous attendee, and I'll restate it. So in the glass case, when you couldn't see the lesion, how did you know you were at the same location? Did you hold this transducer still for 3 minutes? This is an excellent question. So when we are positioning for these patients, we make sure that our arm is comfortable. I actually probably put my arm on the bed, and then I hold the probe lightly, and I do try to hold the probe still in the same location for 3 minutes. We can't always do that, but yes, when you can't see the lesion, if you can get your arm comfortable and hold it in the same position for 3 minutes, then it's easier to see, or it's easier to know that you're in the same location. And the importance here is that even though we didn't see the lesion, what we didn't see was just as important. Didn't see any changes in the enhancement pattern that were different from the liver. It was similar to the liver the whole way through, and we could say that with a certainty. But our dual calipers, the grayscale image, sometimes what we do is we increase the contrast on that grayscale image. So although it's not very beautiful for an abdominal scan for contrast, we can see what we're doing and we can see where we're going.
Another tip I might add to that, Christine, is that if you have a lesion that is very challenging to see and you can get it in a plane where quiet respiration will be visible, if the patient can maintain that quiet respiration, you really never have to move out of that window. So you don't have to take a big breath in and then have it move out of plane. You can just try and focus on keeping it in plane in your grayscale, do a little practice first, and then go ahead and do your imaging exactly that way. So we have another question here, and it says, if the desired images aren't captured in the 5-minute window, is another injection of microbubbles safe in the next 10 to 15 minutes? And we can say absolutely yes. This is something we do very routinely in our lab, where we'll do a number of injections kind of spaced at those 5-minute intervals. So if you don't get everything you're looking for in a single injection, yes, we will add another.
In fact, I will add to that as well. I always tell people, and we do multiple injections, and we have some advanced techniques that we didn't talk about here today that we can do with multiple injections. And I always tell people that if your first injection is never a failed injection, because you can learn from that injection. Do I need to optimize my focus? Do I need to optimize my window? Where did I see this lesion best in contrast? And then what we will do is we will re-inject. We do this quite often here.
So we have another question here. Besides liver, kidney, and thyroid, what other types of lesions are you using contrast on? And that's a great question. Our lab is a little bit research focused, and Dr. Stephanie Wilson, of course, being an expert in the field, has so much to teach us. So we have contrasted many of the solid organs in our lab: liver, kidney, spleen, pancreas, ovaries. What else, Christine?
Yeah, so one of the comments I'll make to this is that when do we use contrast? We use contrast whenever looking at blood flow at a perfusion level will give us more information. So that's anywhere in the body that looking at blood flow will provide more of a diagnosis, because you can use them on aortas, endoleaks, arteries. The uses for contrast just keep growing and growing.
Cardiac, of course, being a huge one as well. Here's an excellent question. Have you ever had to cancel an exam due to extreme obesity of a patient? And that's a very good question. We all know that ultrasound has its limitations with penetration. However, with these tips and tricks about moving around your patient and manipulating the space and really windowing, we find that we get pretty good results with a patient of most body habitus. We have had some patients of an increased body habitus, and we've used our low frequency probes, but we've had quite good success with that, wouldn't you say?
Yeah,
Yeah.
we have. In fact, one of the successes that we've had is patients with an increased BMI who can't fit into the MRI or the CT scanner. They've actually brought them to contrast enhanced ultrasound, and we've had quite a lot of success because we don't need to penetrate down to the spine. We just need to see if we can find a window where we can bring the area of interest closer to the probe. How do you prepare? Oh, so Christopher Schneider, thank you for this question. It's another good question. How do you prepare the bubbles? How much shaking? So although this is a really good question, we didn't get into this in this presentation, but each agent will have its own specific instructions on how to do that. With one agent, it comes with a bubble shaker. We shake the bubbles for 45 seconds. With another agent, it's a manual shake. But actually, Christopher Schneider, you can find a lot of this information online on the CEUS website in preparation for exact preparation of the bubbles. And we follow the manufacturer's recommendations when it comes to preparing those bubbles. So thank you for that really great question. Okay.